So, hello everyone, and welcome to the case 6 of this case discussion series. So, here we have this is the first case, and this is the coronal section CT scan of the patient. This patient presented with symptoms of gastroesophageal reflux. So, on this coronal section of the CT, we can see that there is herniation of the stomach through the esophageal hiatus into the thorax with some peritoneal fat. Gastroesophageal junction is in the normal position, but there is herniation of the stomach through the esophageal hiatus. This is the axial section of the CECT of that particular patient, where again we can find that there is herniation of stomach along with some peritoneal fat through the esophageal hiatus into the thoracic cavity. So this is the second case. This is the axial section of that particular patient. This was an incidental finding. Here we can see that there is some defect in the diaphragm and there is herniation of the peritoneal fat into the thoracic cavity from that defect. This was not a case of trauma, and this was present since childhood in this patient, and it is present posteriorly. There is a defect in the diaphragm posteriorly through which the peritoneal fat is herniating on the right side. This is the sagittal section of that particular patient, where again we can see that there is herniation of the peritoneal fat through the defect in the diaphragm posteriorly on the right side. So this was a case of Bochdalic hernia, and the first case was of hiatus hernia. So hiatus hernia occurs when there is a herniation of the abdominal contents through the esophageal hiatus of the diaphragm into the thoracic cavity. The most common content of the hiatus hernia is stomach. There are two main types of hiatus hernia, which is the sliding hiatus hernia, which is the most common type, which is seen in more than 90% of the cases, and the rolling or the paraesophageal hiatus hernia, which is less common, seen in less than 10% of the cases. Our case was of rolling or paraesophageal hiatus hernia. Some divide them hiatus hernia into four major types: type 1, type 2, type 3, type 4. Type 1 being the most common sliding hiatus hernia. Type 2, the paraesophageal hernia, which was seen in our case, where the gastroesophageal junction is in normal position with the herniation of the stomach. Type 3 is of mixed or compound type, where there is paraesophageal hiatus hernia with displaced gastroesophageal junction. And type 4 is mixed or compound type with hiatus hernia, mixed or compound type of hiatus hernia with additional herniation of the viscera. Coming to sliding hiatus hernia, which is the most common type of hiatus hernia, the gastroesophageal junction is displaced more than 2 centimeters above the esophageal hiatus. This number is to be remembered: more than 2 centimeters above the esophageal hiatus, and the esophageal hiatus is also abnormally widened to 3 to 4 centimeters. The upper limit of normal is about 1.5 centimeters. And on fluoroscopy, we can see that there are more than 3 gastric folds that are seen above the hiatus, which is suggestive of hiatus, sliding hiatus hernia. The gastric fundus may also be displaced above the diaphragm and present as a retrocardiac mass on chest radiograph. The presence of a air fluid level in the mass suggests the diagnosis. Coming to rolling or paraesophageal hiatus hernia, which is less common than the sliding type, the gastroesophageal junction remains in normal location. So it is not actually displaced, which is not the case in sliding. Sliding, the gastroesophageal junction is always more than 2 centimeters above the esophageal hiatus. In rolling type, which is less common, the gastroesophageal junction remains in normal location while a portion of the stomach herniates above the diaphragm, which was there in this particular case. Then there is mixed rolling and sliding type of hiatus hernia, where both the things happen, that is displacement of the gastroesophageal junction as well as herniation of the stomach. So this is a complication of hiatus hernia, and I want you to actually diagnose this. This is actually not a pneumothorax, hydropneumothorax. This is actually a herniated stomach, and this is causing displacement of the mediastinum to the contralateral side, and it's actually called tension gastrothorax. So the second case being the Bochdalic hernia, where the where the abdominal contents were herniating through the defect in the diaphragm on the posterior side, on the right side. It was a non-traumatic case and it was an incidental finding. So Bochdalic hernia are known as pleuroperitoneal hernias, which are commonest type of congenital diaphragmatic hernias. They occur posteriorly and are due to defect in the posterior attachment of the diaphragm when there is failure of the pleuroperitoneal membrane closure in utero. The retroperitoneal structures may prolapse through the defect, like retroperitoneal fat or left kidney. Usually it is present on the left side in infancy, but in adults it is usually seen on the right side, and it is usually incidentally detected. So this is another case I wanted to show you. This patient had a history of trauma, and there is traumatic herniation of the contents. This is a rupture of the diaphragm and herniation of the contents, and there is volvulus, gastric volvulus, that is present. The fundus of the stomach is this, and this is the pylorus of the stomach, and this is actually the duodenum. So the stomach is actually upside down with pylorus continuing with the duodenum here. This is the axial section, that was the coronal section. We can see pylorus here, and this is the duodenum. So gastric volvulus is a type of volvulus that occurs when the stomach twists on its mesentery. It should at least be 180 degrees and cause bowel obstruction to cause gastric volvulus. Merely gastric rotation on its root is not considered gastric volvulus. And the typical triad of presentation is called the triad of Borchardt, where there is severe epigastric pain, intractable retching without vomiting, and inability to pass the nasogastric tube. Chronic symptoms are more common in patients with mesenterico-axial volvulus, which was in this particular case. So organoaxial and mesenterico-axial, these are the two types of gastric volvulus that is present. In organoaxial, which is the more common of the two, the stomach becomes the mirror image of its own. That stomach is rotated along its long axis like this, and along the cardiopyloric line, and which is drawn between the cardia and the pylorus, and it is usually in the setting of trauma or paraesophageal hernia, and the stomach becomes its mirror image in organoaxial type. And then there is a less common mesenterico-axial type, which is less common, and it is seen when there is rotation of the short axis, where there is rotation around the short axis from the lesser to the greater curvature, that is perpendicular to the cardiopyloric line, and there is displacement of the antrum above the gastroesophageal junction. The stomach appears upside down with antrum and pylorus superior to the fundus and proximal body, which was this in this particular case.